Welcome, everyone. My name is Dan Dowd. I'm the VP of Medical Affairs here at Genomind. This is the next series of our Genomind Grand Rounds. Today, we're lucky to have Dr. Joseph Goldberg here presenting on the topic of how I use pharmacogenetic testing. And I think he will talk about how he uses and how he doesn't use pharmacogenetic testing and some of the limitations here, but I'll let him speak for himself. I'll give you a brief background about Dr. Goldberg, and then I'll go through our agenda here for a second. So Dr. Goldberg is clinical professor of psychiatry at the Icahn School of Medicine at Mount Sinai. Educated at the University of Chicago and Northwestern University Medical School, he completed his psychiatry training and psychopharmacology research fellowship at the Payne Whitney Clinic, New York Presbyterian Hospital. He's published over 220 peer-reviewed papers on psychopharmacology and mood disorders, as well as 4 books, most recently, Practical Psychopharmacology, Translating Findings from Evidence-Based Trials into Real-World Clinical Practice. That was published in 2021 by Cambridge University Press. He served on the board of directors for the American Society of Clinical Psychopharmacology and is an editor of the Journal of Clinical Psychiatry. Dr. Goldberg is a distinguished fellow of the American Psychiatric Association and has been listed for many years in Best Doctors in America and Castle Connolly's America's Top Doctors. So that is quite an impressive resume. We're lucky to have him. I'll also mention this, the book that I mentioned earlier, Practical Psychopharmacology. So this was co-authored with Dr. Stephen Stahl of NEI, and Dr. Stahl was nice enough to send us an excerpt from chapter 8, which is the pharmacogenomics chapter. And it's fantastic. It's very readable. It's very balanced. If you're new to pharmacogenetics, I would recommend it. You can find it on Amazon. If you're a member of NEI, I'm sure you can find it from the website as well. But it's Practical Psychopharmacology, Translating Findings from Evidence-Based Trials into Real-World Clinical Practice. It's great. So today's agenda, Dr. Goldberg will speak for 45 minutes. We'll try to leave 15 minutes for Q&A at the end. Some housekeeping stuff. If you look at the bottom of this Zoom webinar platform, you should see a Q&A button at the bottom. Feel free to enter questions there at any time. And at the end of this, I'll moderate questions and we'll do our best to answer them. So that's enough from me. You're here to listen to Dr. Goldberg. So Dr. Goldberg, take it away.
Well, thank you, Dan, for that very kind introduction. Thank you all for taking time out to join today on this topic. Dear to my heart, my very first NIMH grant was a Career Development Award in pharmacogenetics. That is where I learned about the limitations and the strengths of pharmacogenetic testing and the candidate gene approach to looking at predicting pharmacodynamic effects that we think are phenotypes. That is, are they under genetic control, or how much are they under genetic control? So in some ways, what I'll do today is tell you things I've learned over the last couple of decades since then. And by way of disclosure, here are entities that I've been involved with as a consultant and otherwise. And Dan kindly mentioned this new book from myself and Steve Stahl from Cambridge Press. A lot of what I'll be talking about today is drawn from chapter 8. So if you don't want to get the book, you may not need to. And if you like what you hear and see today, you might want to. It's really meant to give kind of a pragmatic overview of using pharmacogenetics as informed by the research world. I trained as an academic clinical scientist. I'm also a clinician, and so I try to navigate both those worlds. And the impetus of this book, which goes into many other aspects of psychopharm besides pharmacogenetics, is really how to draw on the evidence-based literature into the clinic so that you can take data from evidence-based trials and use it to inform your thinking. The other source I'm going to draw on today is the American Psychiatric Association textbook of psychopharmacology, is coming out in its 5th edition, probably later this year. I was honored to write the chapter on pharmacogenetics in that book, and so you'll get a little preview of the APA textbook, which should be coming out later. So here's my objectives: to review examples of targeted use of pharmacogenetic testing in psychiatry, and to discuss the scientific limitations of existing randomized trials using pharmacogenetics to predict efficacy of antidepressants and other drugs in psychiatry. We'll talk about depression a lot because much of the existing literature in pharmacogenetics and psychiatry is around depression, but we'll touch on some other themes. And then last, to discuss the role of pharmacogenetics versus other patient-specific factors to devise what Dr. Stahl and I call personalized medicine in psychopharmacology, or the bespoke approach to treatment in psychiatry. So you're not just treating diagnoses, you're not just going through a treatment algorithm and saying, well, how do I randomly, willy-nilly pick this drug from among others for this diagnosis, but really to try to tailor the fit. So in many ways, this is where pharmacogenetics came from, this notion of personalized medicine, the idea that we could identify characteristics about the patient. Those could be clinical, those could be biological, those could be epidemiological, those could be other factors that will help you decide how to devise a regimen that one size fits one. This will be the regimen that should help this patient based on the following characteristics. And so pharmacogenetics, I mean, really came out of the cancer literature and the hematology literature and the infectious disease literature from sort of the era of Barack Obama, when he talked about really making personalized medicine a priority, and psychiatry has aimed to try to adopt the same technology. I've written about ways in which we can or can't, or do or don't use pharmacogenetics as a precision tool for a very specific purpose. And one of my concerns is the ways in which clinicians will use pharmacogenetics in a very deliberate way and order it the same as you'd specifically order any other test. You don't order an abdominal ultrasound just because the patient has a bellyache and you wonder what's going on. You don't do an exploratory laparotomy just to poke around, hopefully. You don't order an infectious disease panel or an immunological panel as a shotgun approach. You hopefully craft your ordering of biological tests to test a hypothesis. And so one of the points I'll try to make today is we should be ordering pharmacogenetic tests for a reason, to answer a specific question, no different than ordering a CAT scan or an LP or an EEG or an MRI. It's because I have a hunch about something with this given patient. And it's not a Ouija board, it's not a crystal ball, it's not going to read tea leaves and tell you what should I do. It's going to answer questions or affirm hypotheses that you formulate in your own mind about what you think is going on in a very specific way with the patient. So more on this as we go along. I want to divide our thinking into this broad dichotomy of what's been termed safety pharmacogenetics and efficacy pharmacogenetics. They're different and they're complementary. And I'll hopefully argue we know more about safety in some ways than efficacy at the present time. So many of you are familiar with the phase 1 metabolic enzymes for which we know there are functional polymorphisms or SNPs, single nucleotide polymorphisms, that have genetic variation in some subset of the population that will influence the metabolism of drug substrates. So in phase 1, we have the P450 system primarily, and we know that certain patients will have a genetic predisposition to make gene products that are normal. We call those intermediate metabolizers or normal phenotypes, or poor metabolizers or ultra rapid metabolizers. So poor metabolizers will manufacture or transcribe a gene product that is less active than the normal or extensive metabolizer phenotype. The system will gunk up. Implications: a parent drug won't metabolize through its P450 substrates efficiently. You could get more side effects, hence safety. You also might not get efficacy because if a drug is a prodrug and it's a P450 substrate of a particular isoenzyme, you won't convert the prodrug to its active metabolite. Examples would be like venlafaxine. It's a 2D6 substrate, and if I happen to be a poor metabolizer at 2D6, I need to convert venlafaxine to O-desmethylvenlafaxine to make the drug do anything for me. And if my 2D6 system is kind of shot, good luck. I'll just gunk up the system with a lot of pro-drug, I may get some side effects. I'm not really going to get much efficacy. Similar with risperidone, has to get metabolized through 2D6 to 9-hydroxy risperidone in order to make the active metabolite. And you know about opiates and conversion of morphine. So this comes up in pain medicine. So you may get side effects from poor metabolizers. And ultra-rapid metabolizers, the substrate will zip through. You may not get efficacy because you're not getting a bioavailable delivery of the system. And that may influence side effects as well. So much of what we think about when we order pharmacogenetic testing is, will the drug make it through, and what is the best drug given a particular patient's phase 1 metabolic profile. Then we have some drugs that go through phase 2, UGT glucuronidation, drugs like lamotrigine, for example, or lumateperone, new drug that just came along, goes through UGT1A1. If you have a polymorphism there, that may influence whether you'll get an active drug product, metabolite, whether you might build up metabolites, might build up parent drug and get more side effects. Then we have the holy grail, which is efficacy. And this is why a lot of people, I think, order pharmacogenetic testing and may or may not be disappointed with the results. That is, can a test result tell me which drug is going to work? We do that either by looking at single nucleotide polymorphism candidate SNPs. That is a known variant of some receptor or some metabolic enzyme like COMT, or a gene product like BDNF, and we read a paper, I'm going to talk about this more, and it says, ooh, these patients have a better response if they have the veil met for this BDNF polymorphism, or these patients have a better depression response if the serotonin transporter gene has the long variant. And so we test that out, and we ask, if I do pharmacogenetics, will knowledge of specific candidate gene polymorphisms influence outcome? Maybe, and we'll look at that data. One of the issues that sometimes comes up, though, is, well, pharmacogenetics may tell us which drugs are not going to work, either because the patient's a poor metabolizer, an ultra-rapid metabolizer, or they have a low activity variant of something, and so don't use this. Sometimes it's a little bit tough to differentiate in our minds the recommendation from a test result of don't use this as opposed to do use that. It's a subtle difference, but it's important. We sometimes don't really know that the alternatives are going to work better. We just know that the drugs for which patients may have some conflict are not going to work as well. I'll show you some examples as we go along. For metabolizer genotypes and ultra-rapid metabolizer genotypes stratify across ethnic, racial diversity. And this is one of the points that doesn't always get captured in randomized trials. One generally needs enough of an ethnically or geographically based homogeneous population because the allele frequencies of some of these vary. So if I have a predominance of Ethiopians, for example, for 2D6, probably going to get different findings than if I'm looking just at Asians or Latinos, and even within regions, there's variability. And we also don't even really know much about allele frequencies with all of the pertinent P450 SNPs, like 1A2, for example, or 3A4 ultra-rapid metabolizers. But one other point to make here is notice that in general, these frequencies are not huge. So, it's often been said if the patient's a poor metabolizer or a URM, it's going to lead to problems. That is true, but we may be talking about less than 10% of a population as stratified by things like ethnicity or geographic origins. So just another point to keep in mind when you're reading a clinical trial and you're deciding, can I translate this into my practice? Who's the population? Are they ethnically stratified? Are the allele frequencies different from one group versus another? So safety pharmacogenetics, if ever there should be a role here, it ought to be to say, hey, I bet all the poor metabolizers of the relevant drugs that are substrates for the enzymes that break down the drugs of interest are going to have just a boatload of side effects, right? There's not a ton of research testing that hypothesis yet. And what there is modest. So I give as an example, we're going to talk about this study in a few minutes a little more. You may be familiar with the GUIDED trial, pharmacogenetics, combinatorial pharmacogenetics panel that was implemented in about 1,500 or so major depression patients randomized, so a randomized trial, to either guided care or treatment as usual, and was looking at outcomes for efficacy in depression, but they secondarily looked at side effects. And what they ended up finding was, to my mind, a little surprising. They did not observe a significant difference in what they measured as the usual treatment as usual or pharmacogenetics guided in the mean number of side effects or the proportion of subjects who experienced side effects, which were remarkably low, about 15%. I'm lucky if I can get only 15% of patients to have side effects. The number of side effects was low to begin with. So there may have been a floor effect in terms of what was chosen. I wished, and I read an editorial on this, that when the guided study did a second look at their own data, enriching it for individuals who were prescribed baseline drugs that were discordant for pharmacogenetics, and they actually found a better signal. They didn't look at whether side effect burden was different there. So I'll explain that a little more as we go along, but the point I want to make here is that we don't have swaths of data telling us, oh yeah, I can predict, broadly speaking, whether side effect load is going to be different based on the printout that I get. So that may lead us to look a little more specifically at specific SNPs. SNPs, individual candidate genes, are a little 10 years ago. We're much more interested in genome-wide association studies now, but I'm going to make an impassioned plea that SNPs are still important because there are particular candidate genes that do tell us things about safety as well as efficacy. Let me give I'm going to sprinkle in some clinical examples as we go along. These are real patients of mine. Here's a 32-year-old woman with a history of recurrent major depression, previously been stabilized on fluoxetine, 60 milligrams a day, after having not responded to escitalopram, yes, that is a 2C19 and 3A4 substrate, or to duloxetine, which is mainly A1A2 and lesser of a 2D6 substrate. She opted to discontinue her fluoxetine to get pregnant and conceived 8 months later. Her depression came back in the first trimester. And then the question from the OBGYN was, first, should she resume the fluoxetine? Yes. But the second, and way in which pharmacogenetics is helpful, is, well, should we assume the necessity of a target dose of 60 milligrams a day? So why is this a good example, at least in my opinion, of pharmacogenetics? Well, my hypothesis was that fluoxetine is a 2D6 substrate. We don't know much about her 2D6 status from escitalopram. It doesn't go near 2D6, and duloxetine isn't that potent for 2D6. So if she needed 60 milligrams a day, my hypothesis is that she's probably an ultra-rapid metabolizer, since most people do well with 40 milligrams a day in non-complicated depression. 60 is okay, it's a little bit high. And if she is an ultra-rapid metabolizer, then the answer to the question to the obstetrician is, yeah, she ought to be on 60 milligrams a day from the get-go, because 60 milligrams a day for her may be more like 20 milligrams a day for anyone who's not an ultra-rapid metabolizer. And you might say, well, why don't you just do a blood level? My friend Steve Stahl likes to measure blood levels of everything. Problem is, there's not an established correlation between serum fluoxetine blood levels and antidepressant response. Thank you, Dr. Amsterdam, in this paper from 20 years ago. So you can't just say, let's measure a level and guide it that way. So lo and behold, I tested my hypothesis. Guess what? She was an ultra-rapid metabolizer at 2D6, and with some confidence, I was able to tell both her and her obstetrician she should start on 60 milligrams of fluoxetine and expect to have the same response that she did before with no concerns otherwise. And indeed, that was a successful outcome and a healthy baby. Here's another example. 21-year-old man with schizophrenia, unresponsive to aripiprazole, a 2D6 substrate. 20 milligrams a day was switched to risperidone up to 4 milligrams a day with neither improvement nor adverse effects. He's then switched to its long-acting injectable formulation, aripiprazole long-acting, on suspicion of poor adherence, but continued to show neither benefit nor side effects after 2 cycles of 20 milligrams a day. This is risperidone, long-acting injectable. Then the dose was brought up, the risperidone constant at 50 milligrams a day, and still not getting better. So you thought it was just non-adherence, so you switched to an LAI, but that didn't change anything. So how about we do pharmacogenetic testing on this fella? And lo and behold, he's a 2D6 poor metabolizer genotype. So why is this relevant? 2D6 poor metabolizer, he's not gonna break the prodrug of risperidone down to 9-hydroxyrisperidone. So let's give him 9-hydroxyrisperidone, otherwise known as paliperidone. And to boot, you thought it was just a non-adherence issue. Let's give him oral paliperidone, the active metabolite, 6 milligrams a day. He did very well. So here's an example where pharmacogenetics was useful to dispel the presumption that it was just non-adherence to be overcome with a long-acting injectable. It actually tested out the hypothesis that in this case, a poor metabolizer genotype made it hard for him to convert the prodrug to the active drug. Got that? Right, so these are examples of using pharmacogenetics to test hypotheses. Here's another one. This one came from my wife, who's a consultation liaison psychiatrist. Real patient, 24-year-old man with opioid use disorder, getting methadone maintenance up to 120 milligrams a day. Yowza. He complained of withdrawal symptoms as well as craving in the early evening, and his methadone clinic was very reluctant to further increase his meth beyond 120. So my psychiatrist wife said, well, let's get pharmacogenetic testing, and lo and behold, he's an ultra-rapid metabolizer of 3A4, which metabolizes methadone. And so he's gobbling it up. And the reason why he's having true withdrawal at the early evening is not because he needs a gigantic dose, but he's probably running out and having an end dose effect. So the decision was made not to raise his dose, but to change his dosing from once to twice a day. And he got all better. And my wife was a hero, which makes me happy. Now, here's something a little more fun and clever. 30-year-old white woman with bipolar depression had not improved with trials of lorazepam, cariprazine, lithium plus lamotrigine, all evidence-based treatments for bipolar depression. Her psychiatrist says, well, let's try olanzapine fluoxetine combination. That is an FDA-approved treatment for bipolar depression, but she's reluctant to concerns about weight gain, which is something we're often very concerned with. Luckily, the psychiatrist read the paper by Houston et al. In the Journal of Clinical Psychiatry, and in response ordered pharmacogenetic testing and looked at 2 SNPs of interest, the DRD2 gene and the HTR2C gene with these particular loci, knowing that there's a risk allele associated with weight gain with olanzapine. Don't believe me? Have a look at Houston's data. On the left, the DRD2 allele, stratification of weight gain over the course of 8 weeks based on genotype. So it turns out if you were lucky enough to get the G homozygosity genotype, you didn't gain weight. This is with DRD2. Risk allele is A. This lady's G. Yes, good. Houston is making us think we don't have a problem. And then on the right, we have the serotonin 2C allele. You know, the serotonin 2C receptor is associated with psychotropic weight gain from serotonergic drugs. The drug lorcaserin at one point was an agonist at that receptor, and it was a potent weight loss drug. Unfortunately, it turned your cardiac valves into cardboard. So the FDA ditched that drug. It was a very good example of a targeted intervention for this receptor. Anyway, there's a risk allele for 2C. It's the G allele. So if she's C, we're in luck. C doesn't have much weight gain. So you might use pharmacogenetics, as we did in this case, to say, ma'am, you haven't gotten better with 1, 2, 3 evidence-based treatments for your ailment. I'd like to give you this one, but because I did pharmacogenetics on you and I read the Houston paper, I can tell you that it's not a guarantee you won't gain weight, but you have 2 protective genotypes, right? DRD2 homozygosity at G and 5-HTR2C C homozygosity, which should protect or diminish the risk. Fair point to make. Far more compelling in a dialogue with a patient than to say, yeah, let's just try it and see what happens. Speaking of weight gain, so we have a host of candidate genes, I'm not going to go through all of these, that have known risk alleles. This is what I meant when I said I'm making a bid, well, for candidate genes and as well as, I guess, combinatorial pharmacogenetics as opposed to GWAS, because these are all SNPs, functionally significant SNPs that have known relevance for the potential for psychotropic weight gain. Now, there may come a point, and maybe Dave can tell us if Genomind has this yet, of a cassette for weight gain that will list a combinatorial panel of examples such as these, that you might be able to not just sort of look at a colored sheet at the front and say, it's okay to use this drug or not, but rather to say, here are the collective risk alleles that will inform you about the probability that such and such a patient is predisposed genetically for weight gain. This could be quite paradigm changing, because we often are averse to using drugs that have a higher liability for weight gain because it feels like a shot in the dark, or we imagine they're all going to gain weight. I have one patient with schizophrenia who's been on clozapine for over a decade. Skinny as a rail. I've never done pharmacogenetic testing on her. She's a rare patient. She's done fantastically with the clozapine, but maybe someday I will, just to answer for myself, gee, I wonder if she lacks the G allele at ADRB3. I wonder if she has the T allele on 5-HT2C, because that would help me consolidate in my mind the next person who comes along with more of these protective genotypes. I might be more inclined to say it's safe to use a drug that's got a higher metabolic liability for you than someone that has the more predisposing risks. Here's some more examples. For time's sake, I won't go through them all, but this is coming in that APA textbook later this year on pharmacogenetics. So patients very concerned about sexual dysfunction. There's a number of glutamatergic genes that have been shown to be risk alleles for sexual dysfunction. I had a patient once who had a fantastic response to an MAO inhibitor and nothing else, but wanted to stop because of sexual dysfunction. So it's a real problem. If we could anticipate the likelihood of that from happening with a panel such as this, we might be able to say to somebody on the front end, your risk is not luck of the draw. We know something about your predisposition. Another example, clozapine and sialorrhea. In the DRD4 gene, there's a known tandem repeat sequence that will about triple the likelihood of seeing sialorrhea. Not saying let's run out tomorrow and do DRD4 in every clozapine patient, but it's another example of a functional polymorphism that has a known association with a phenotype. So imagine if we could think of all these phenotypes: sialorrhea, sexual dysfunction, weight gain. How about tardive dyskinesia? I mean, this, to my mind, is where I sure hope pharmacogenetics will be taking us in the nearer future. Here are some examples of risk alleles that are correlates of tardive dyskinesia. So those of us who give talks about TD will say things like duration of use, age over 50, having a mood disorder, etc., are all risks for TD, and there's an annualized risk. Boy, I would love to give an updated talk in 2025 that says, oh, and if you happen to have the G allele on HSPG2 and the C allele on SLC18A2, etc., can we refine the risk? Just imagine how that would allow us to prescribe with the precision we talked about at the beginning. But we're not in 2025 yet. So there's a few things in safety pharmacogenetics that are known for practical importance. Give some examples here. 2D6 poor metabolizers. We do have a boxed warning in the case at least of iloperidone, because there's a potential for dose-related QT prolongation with this substrate of 2D6. That means that the box warning says, before you give Mr. Smith iloperidone, you need to know if he's a 2D6 poor metabolizer, and you sure don't want to give him, fluoxetine or paroxetine or a 2D6 inhibitor, because it's going to raise up levels of iloperidone, which could go with dose-related QT prolongation. So I don't know how to tell if Mr. Smith is a 2D6 poor metabolizer unless I genotype him. That's not said explicitly in the package insert for iloperidone, but that's essentially the implication. And then we have some of these other examples here. This comes from the Dutch Pharmacogenetics Working Group. You need to know if somebody's a 2D6 poor metabolizer, you've got to lower their dose of atomoxetine. Otherwise, they're going to have like 5 times the level of what they would otherwise. Vortioxetine, max dose of 10. That's the same reason why if you mix vortioxetine with bupropion, you can't go beyond 10, because bupropion is a 2D6 inhibitor. But if someone is genotypically a 2D6 poor metabolizer, well, you'd like to know that. Otherwise, you're going to likely have an overshoot and toxicity concerns. All right, you get the picture of ways in which pharmacogenetics is here meant to answer a specific question. Here's some more examples. This is looking at 2C19. I'm not going to go through all of these, just one needs to know these things if there's a concern about tolerability with poor metabolizer, or again, in the case of citalopram, we have another warning about QT prolongation. If someone's a 2C19 poor metabolizer, they're at risk for potential torsade. There's another box warning. I'm sure you all know about this one. This in some ways is one of the most compelling examples of when we need to do pharmacogenetics. We must test the presence of the HLA-B1502 gene in any, back to ethnic stratification, any Southeast Asian individual taking carbamazepine, because there is a 2.5-fold increased risk of their developing Stevens-Johnson syndrome or toxic epidermal necrolysis. It's not just a suggestion, it's a boxed warning. This is the kind of pharmacogenetics data that I think, as more things like this come along, will really help us with precision medicine in psychopharmacology. So it's not guesswork, and you don't say to somebody, well, there's this potential risk, we'll watch, we'll see what happens, but to actually predict it. Some more preliminary data, similarly looking at these other HLA haplotypes with lamotrigine in Stevens-Johnson syndrome, and in fact, even HLA-A star 3303 may be protective. So I don't know that we go around routinely with lamotrigine among Han Chinese patients checking HLA-A star 3303, nor am I saying that's the standard of care, but we're moving more toward this mindset. So we don't just say, could this happen, but rather, what are the potential predictors? This has always been another holy grail. Clozapine agranulocytosis has some genotypic influence, and we don't have a clincher candidate gene prediction of who's going to develop agranulocytosis with clozapine. It is one of the obvious obstacles that limits our ability to use clozapine. The only drug that is FDA approved in treatment-resistant schizophrenia, the only drug in our pharmacopoeia that carries a label that says reduces the risk for suicidal behaviors in schizophrenia. It's not lithium, it's clozapine. So at last count, there's some preliminary data looking at these HLA genes and clozapine-induced agranulocytosis. We don't yet have enough of an affirmed data set to say, from like an FDA standpoint, do this pharmacogenetic testing before starting clozapine. But imagine the day hopefully will come when we would be able to say, before we start clozapine, let's see what your risk is, because imagine if we could spare the weekly CBCs or the worry about actually having agranulocytosis occur. Here's another phenotype. I give you an antidepressant, an SSRI, and you get manic, you have bipolar disorder. How common is that? What's the risk? So the serotonin transporter gene, as many of you I'm sure know, has a short and a long variant, and there's subtypes of the long variant. And the short allele has garnered much interest in all kinds of things, from antidepressant response to suicidality to the presence of depression severity. Here's an interesting study from a few years back. It's a meta-analysis that essentially said bipolar depressed patients who happen to have the S allele at the serotonin transporter gene are about 1.3 times more likely to develop an antidepressant-induced mania with an SSRI than are subjects with the long allele. Now, again, how much does this configure relative to all the other potential risks for antidepressant-induced mania? We don't know, but it's another piece in the puzzle, as people like to say. If one is particularly concerned about the safety of using an antidepressant, an SSRI, in a bipolar depressed patient, a controversial area unto itself, knowledge of genotype at SLC6A4 can confer some additional data, right? So I've written a lot in my career about this risk overall for safety versus risk with antidepressants in bipolar depression. And, we would be well served just to know if this data point is here. If someone is LL homozygous at SLC6A4, particularly LA subtype of the allele, doesn't mean go ahead and give them all the SSRIs you want, but it does mean that their relative risk for mood destabilization is less. All right, so here's the biggest randomized trial looking at efficacy with antidepressants pharmacogenetics, the so-called guided study. This study, which I've been involved with some of the dialogue around in the literature, is kind of messy for a few reasons. So the main outcome, which was, does your symptom improvement on the Hamilton scale get more better with guided treatment than treatment as usual, that was a negative finding. And one of the problems with pharmacogenetics, we're looking at complex traits, is power. And this is one reason why genome-wide association studies are often much preferred, is to pick up multiple genes of small effect. If the primary outcome is negative, all you can do is post hoc nominal studies to generate hypotheses, not test them. So the primary outcome was negative. Secondary outcomes looked at response and remission, and these p-values are nominally significant. They did about 25 post hoc analyses, and so you have to do what's called the Bonferroni correction. And so these are not statistically significant. They're suggestive, which is nice, that it could help frame the next study. But if you go by this alone, the remission rate with pharmacogenetics was very low. The number needed to treat, how many people you have to do testing on to get an additional beneficial case, was 19. And the National Institute for Clinical Excellence says we like NNTs under 10. Plus, the remission rates were just darn low all around in this study. Treatment as usual got you a 10% remission rate, and pharmacogenetics bought you an extra 5 percentage points. So it was informative, but it's not quite ready to sort of compellingly tell your next patient, I'm going to get your remission likelihood from 10% to 15%. And if 19 people go ahead of you, I'm even more likely to see that outcome. They went back and they sort of cherry-picked the subjects who were taking medications that had known gene-drug interactions at baseline. Doing that lost 40% of their sample. The NNT came down a little bit to 13, but again, look on the right. So this meant an extra 3% of patients achieved remission. So helpful, but not an oh my gosh home run. It sure didn't mean throw away the clinician and just plug the pharmacogenetics into a computer and pick a drug, because all it did is buy you an extra 3 percentage points for remission over and above treatment as usual. Here was a meta-analysis of efficacy in pharmacogenetics, which said that, if you use pharmacogenetics, there's a 1.7 times greater chance of success, except most of the data came from the study I just showed you, and that violates the laws of meta-analysis, where no one study is supposed to contribute more than, well, certainly not 67%. So real preliminary, we don't have a ton of studies, and these sample sizes are nowhere near the numbers that we need for genome-wide association studies. And now to make life more complicated, here's all the non-genetic things that go into pharmacogenetics and the limitations that we have. We need replication, adequate power, sham guidance, that is, this group of clinicians is getting data and this group is not, standardization, reliability, we don't know about adherence, ascertainment, bias, racial stratification, and then here's all these other things that influence depression drug outcome: chronicity, age at onset, baseline anxiety, depression subtypes like psychosis, chronicity, comorbid anxiety, social isolation, education. These are all established moderators of outcomes. So I want to bring in this word moderator, one of my favorite words, all in that book that I mentioned earlier. These are predictors of outcome, baseline characteristics. Pharmacogenetics is one moderator among many others: age at onset, baseline severity, chronicity, episode number. I submit to you that if you're going to use pharmacogenetics, or even if you're not, but you're thinking about personalizing pharmacology, you can't treat diagnoses. You are, not to be treating the patient, you are recognizing the collective moderating factors that will influence outcomes. So it'd be very nice to know what your 2D6 genotype is. I also want to know if you have a history of childhood trauma, if this is your first depression or your 40th, if your age at onset was before puberty, what your severity level is, sex, familiality, psychosis. These are all characteristics that will influence outcome. Mediators are things that happen after you've started the treatment that can muck up outcome, like non-adherence or drug interactions. So Helena Kramer, who developed this language, says if you don't pay attention to these factors, it's a big explanation for why our drugs don't work. So my point here is that pharmacogenetics represent one of a number of moderators, and truly tailored personalized treatment takes into account all moderators. So in the time we have left, I'm just going to go through a few more examples and then we'll sort of wrap up. So I was making a pitch for candidate genes still. Here's the SLC6A4 locus, serotonin transporter gene. I actually like this study a lot because it took into account other moderators. Dr. Porcelli and colleagues said, okay, if you're short on SLC6A4, your chance of success with an antidepressant is 1.7 times less than if you're long. But that only applied to older women who were white and had late-aged onset. Those are those moderators. Again, you can't apply this to any and every patient. You have to craft this contextualization alongside all the others. Here's another SNP of interest. Many of you know the methylene tetrahydrofolate reductase enzyme responsible for transporting folic acid across the blood-brain barrier. This is a beautiful example of where pharmacogenetics should have worked. There's a known SNP at MTHFR, the G677T variant. That turns out if you have a low activity version of this gene, you ought to be a good candidate to take L-methylfolate, because you're not going to make enough methylene tetrahydrofolate reductase to methylate folic acid and bring it across the blood-brain barrier. So let's give those people L-methylfolate. George Papadakis did this study. Oh, close but no cigar. It wasn't statistically significantly different. His finding was in the right direction. He said, yeah, if you have the T allele, you are more likely to respond to L-methylfolate, but it wasn't statistically significant. Power may be an issue, 75 subjects, bigger sample size. So, oh, close but no cigar in terms of predicting efficacy. Here's some other SNPs that have been looked at. I'm not going to go through these all, just bits and pieces that tell us things along the way. A couple more examples, and I'll stop. So here's an interesting post hoc analysis from Alan Schatzberg. 34-year-old man, drawing on Alan's work, 34-year-old man with major depression and GAD and ADD is taking sertraline with a partial response. Previously didn't do that well with amphetamine salts and methylphenidate or bupropion, and pharmacogenetics testing was done. So not to say which drug is going to work, but just I'm curious about 5-HT-LPR, that's the serotonin transporter gene, because I read Alan Schatzberg's paper with Reimer and colleagues from 10 years ago, which said, funny thing. Turns out if you happen to have SS homozygosity at the serotonin transporter gene, for whatever reason, you had a better response to augmentation of sertraline with atomoxetine. The norepinephrine dopamine reuptake inhibitor that in itself was not successful in augmenting sertraline to have an adjuvant antidepressant response. It only worked in the SS genotypes. So I don't mean this to tell you run out tomorrow for all your sertraline partial responders, genotype them at SLC6A4 and put all the SSers on atomoxetine. But if you want to, I'm not going to argue with you, because this would be evidence-based. It's preliminary. It's a post hoc analysis, but it's the kind of thing that helps us cone down who's a good candidate. Another example in the world of ADD. COMT converts dopamine to norepinephrine. If you have a low activity variant, this is a meta-analysis which says if you have the low activity variant, you're not going to be as successful in degrading dopamine to norepinephrine. So therefore, by default, maybe you want to use a non-stimulant in these patients. And that's not the same thing as saying, hey, I bet you're going to do much better with clonidine or guanfacine or atomoxetine for your ADD. All I can say is I'm not so enthused about the likelihood that methylphenidate or amphetamine is going to work for you if you happen to be met at COMT. So in a way, it's not pointing us to what to use as much as to say, don't get too excited about what you might otherwise be inclined to use. There's a whole bunch of drugs in schizophrenia that have tried to look at antipsychotic response. The data are mixed, so I'm not going to go through them. Here's one last example, then I promise we'll wrap up. Lithium response in bipolar disorder. 31-year-old man, bipolar disorder, predominantly treated with second-generation antipsychotics and breakthrough symptoms, tolerability troubles. His psychiatrist was reluctant to give him lithium because of concerns about end organ risks and the perception that lithium was not as effective as most people think. Somebody did pharmacogenetics and noticed the following SNPs. I invite you to have a look at this really interesting study by Pagani and colleagues. So this is a 20-year overview of all the pharmacogenetics that we know about lithium, and I've condensed it for you to these 4 SNPs that seem to have some robust predictive value for lithium response. Keep in mind, lithium has a familiality. If proband got better with lithium, 2/3 chance that their first degree relative will as well. So lithium's a really good example that lends itself to pharmacogenetics. So glycogen synthase kinase 3 beta XBP1 NTRK2 BDNF, what the hey? If Mr. Smith happens to have these favorable response alleles listed on the right, he's C at GSK3 beta, he's C at XBP1, he's TT homozygous at NTRK2, and Val MET at the Val 66 MET SNP for BDNF. Doesn't mean, oh my gosh, run, don't walk to take lithium. But you're on more solid ground suggesting lithium. And this is alongside the clinical moderators of lithium response, like a positive family history of lithium response or pure euphoric mania. So this I give as just an example of the kinds of ways in which we are hopefully moving toward being able to use pharmacogenetics, not as a crystal ball, but as an assay for helping us frame treatments. Here's a quick study looking at naltrexone responders in alcohol use disorder. Wade Berrettini's group years ago showed if you happen to have this variant in the mu opioid receptor, you are more likely to respond to naltrexone. Naltrexone doesn't work for everybody, and some would say it doesn't work for many people. But you might want to genotype OPRM1 and see what you get the next time you're contemplating naltrexone, especially in a harder to treat patient. I'm going to skip. There's some data with cocaine use and looking at SNPs to predict drug response. These are all preliminary. I'm just going to skip these for now, but just be aware there's some examples of other SNPs that have been post hoc and looked at to try to anticipate might a particular drug work, to give us a little more guidance. So this is from the APA textbook coming out, Pros of Pharmacogenetics. Well, certainly gives us safety information for specific at-risk groups, like I showed you the HLA-B 1502 risk for Stevens-Johnson syndrome in Southeast Asians, or any 2D6 poor metabolizers you're even thinking about giving 2D6 atypical antipsychotic substrates to, like iloperidone, or possibly even aripiprazole for QT prolongation. Can affirm suspicions about lack of efficacy if you're thinking about non-conversion of prodrugs to active metabolites, and anticipating some of the possible specific adverse effects. I'd love to see that cassette come along someday with weight gain and metabolics, for instance. On the cons, we're still waiting for more robust data to predict drug efficacy. Our tests tell us more about what not to use than what to use. Still some uncertainty about which genetic factors contribute to response relative to all these non-genetic factors. Sheldon Prescorn has made the point that, if you just know your P450 system backwards and forwards, you'll pretty much get the same results as you would in terms of a pharmacogenetics output, at least when it comes to phase 1 metabolic genes. Just pick a different metabolic pathway. Power limitations, SNPs technically don't give us nearly as much data as GWAS do. We got to account for population stratification, like I showed you before with that Porcelli study. It only worked SLC6A4 only worked in older white women and is it cost effective. So I think it's my last slide. Never order a lab test without a reason. Read the SNPs, not the bins. Know how to interpret these studies. This wonderful book has all kinds of information in chapter 8 about how to sit down and interpret the output, not just look at the bins. Read the numbers. Don't think of these as crystal balls that'll predict any and all outcomes. Use it as any other biological test. And you know what? I'm just going to stop here and hope I haven't overwhelmed you with too much information. I'm going to turn things back to Dan.
All right. Thanks, Dr. Goldberg. Fantastic. I love your case examples, like the book chapter, extremely balanced. So thank you. I appreciate this. You have a lot of questions in here. I'm positive we're not going to get to them all. I'll ask my question first, and then we'll jump into some of the audience questions. So tell me your future pharmacogenetics. You kind of alluded to it with, you mentioned this weight gain cassette, right?
Yeah.
So I'm thinking polygenic risk scores more for these pharmacogenetic parameters. Tell me your vision of the future of PGF.
Yeah, so, we don't have the replication yet for individual SNP studies to say with confidence, I'm going to avoid clozapine for you, or you're not a good candidate for olanzapine. That Houston study I showed you is an example. If we get replication, and if we can actually increase our power with a polygenic score, then we might be able to make much broader use of drugs we already have that we avoid in patients because we're worried about side effects. Same with lithium. like I showed you that example before. So until we invent new drugs, which we're still doing, we might be able to more wisely use the ones we have by being able to put a combinatorial package together that will answer specific questions, not just global response remission, or not just number of side effects. That was such a crude variable, I thought, in the guided study, but particular side effects. So that's the most proximal way in which I see pharmacogenetics, in the next, I don't know, 5 or so years moving.
Okay, thanks. We'll jump into some audience questions here. First one, sort of a clinical operations type question. So question is, it sounds like you would discourage PGX as part of an intake assessment. Most of our patients are so complicated by the time they present to us that it seems a genetic assay is a wise next best step, and that patients are sort of automatically requesting this. So how would you respond to that?
Yeah, the same as I would say, do you MRI every patient's brain and LP every patient and do a full body CT scan? I mean, you have to use this as a tool to answer a question. It is not a crystal ball. Once a week, I get a patient calling me saying, do you do that test that tells you which drug is going to work? And I say, what test is that? And they say, don't you know you're supposed to be a big shot psychopharmacologist? I say, oh, you mean pharmacogenetics? It's not going to tell you which drug to use. It's going to answer a particular question about whether you have a likelihood of an adverse event with a particular drug, a non-response with a particular drug, certain things to avoid. And at that point, they say, well, that's not what I'm looking for. So no, I see absolutely no evidence base to just use this as like a universal dipstick. It's to answer a specific question.
You answered my next question already, which was going to be, how do you temper a patient's expectations to pharmacogenetic testing? But you just answered it, so thank you.
And I don't want to be at all pessimistic. I mean, the same as when patients come in and say to me, can I get a brain scan, right? What? What do you mean? Oh, I read there's this place that does, $4,000 scans. So I think we just have to, as you say, give them some scientific context about what our technology can and can't do.
Okay, so a couple of questions have some very specific genetic questions here. So maybe we'll double team these if you're, not familiar with the particular genes. ADRA2A, how should ADRA2A impact a decision to initiate methylphenidate versus an amphetamine?
It's another variable. So it's a particular SNP that may be informative. I think a key question, though, is how big is the overall difference between outcome with methylphenidate and amphetamine? If same with COMT and looking at just how meaningful will the low activity variant be to dissuade me from using amphetamine? Plus, it's not like we have a zillion options for ADD. So you could certainly do this, or you could say, well, we have 2 and only 2 major classes of stimulants. We can try one and try the other. I can't tell you with 99% confidence that any test will direct us to one versus the other. I think it would be a little more pragmatically helpful if we had many, many options, and this was to choose from among them. So at the moment, we've only got 2.
Okay. Weight gain pharmacogenetics. So do these weight gain genes play a role in normal risk of weight gain beyond the use of medications? I know MC4R does, but I'll let you answer the question.
Yeah. So, there are certain people, never mind psychiatrically ill, people that are overweight and can't lose weight, no matter what they do. So I'm not an expert in obesity outside of iatrogenic obesity, but yes, if you want to say that certain people may just be metabolically predisposed to either inefficient burning of glucose, maybe a predisposition to insulin resistance, or otherwise just have a much harder time maintaining a normal body weight. Yes, this may come out of 23andMe before anything else. Talk about big data to identify whether or not there are genetic risks. I'm pretty sure there are companies out there that are already doing this, and will 23andMe type approaches, never mind iatrogenics, and we'll just say, yes, you have these genetic risks. But I guess the question is, how will that translate? For instance, I was so sad when lorcaserin bit the dust. Granted, you don't want to kill anybody with cardiac valve disease, but here is an example of a known risk. If you have antagonism or blockade at 5-HT2C for whatever reason, satiety is different. And lurcaserin was an agonist at that receptor. So it was a really clever strategy to try to modulate the serotonergic role in appetite. Sadly, that particular drug didn't work out. Similar to sibutramine, another example of a serotonergic targeted drug that was trying to get at 5-HT2C. So whether the weight gain is caused by drugs that indiscriminately bind to 2C, like atypical antipsychotics, that old Gavin Reynolds study with risperidone years ago, or whether it's just because someone's activity at that gene is genetically predisposed. Long answer to say, yes, I think this could be invaluable information for managing obesity.
Yeah, I think a corollary to that would be, I think it's called semalanotide, which is one of the MC4R modulators, which will likely get an approval for weight gain. The question,
Rimonabant never went anywhere. Remember that cannabinoid receptor blocker, because it caused depression. I guess my only other concern about messing with the cannabinoid system comes from the Rimonabant data, that old drug that was thought to be an appetite suppressant, the anti-munchies drug. So we have to just make sure there's no adverse psychiatric effects.
talk a little bit about methylfolate. Any instances where you would not use it?
So there's other things that work better and have a bigger effect. It's benign. It's safe. It's, I think, got a more compelling story on paper than in real life. I don't think I've ever seen a treatment-resistant depressed patient become undepressed without methylfolate. If we're talking about people that have failed to respond to 2 or more adequate trials of traditional antidepressants, which brings us into the technology question. You know, STAR-D taught us if 2 trials didn't work for you, you know, your odds are like under 20% anything will work. And, you know, I've known people that have failed 8, 10 trials to get pharmacogenetic testing. It's not like the testing is going to widen the pool of available options. So non-response to 8 treatments, has bought you ECT or an MAO inhibitor or neuromodulation. It's not like, this tricyclic's going to work for you, because these are not broad spectrum drugs. So I think that we have to think about number of failed trials and persistence of depression as an important moderator of outcome. And if anything, pharmacogenetics might be useful earlier on than later on. But for these very, very refractory patients, it's not like it's going to point us to a new drug. It's just going to shuffle the deck a little bit more. And it's the same old existing deck.
I think we have time for one last question. So you spoke quite a bit about depression, bipolar, pharmacogenetics. Talk a little bit about the literature base for anxiety or pain pharmacogenetics.
I'm not as firsthand familiar with the pain world, so I may defer that one if you know more. Anxiety is a tough one. For one, we don't have fantastic anxiety treatments, right? We've got benzodiazepines, we've got serotonergic antidepressants, we've got gabapentinoids, and then we've got junky stuff like antihistamines, arguably 5-HT1A partial agonists like buspirone, and some of the newer drugs like vilazodone or cariprazine or 5-HT1A partial agonists. But anxiety, in my view, is one of the hardest things to treat. When it's present with depression, it's one of the strongest predictors of poor response. I have not seen firsthand such excellent guidance from pharmacogenetics in how to overcome that hurdle. Usually when anxiety is present, it just means it's going to be a much harder road to traverse. And we don't have a lot of options. If we had a plethora of options, if this was infectious disease or oncology, and we were just matching a genotype to the right treatment, it's one thing. But here we're saying you've got a very negative predictor of outcome to begin with. So from the universe of treatments, we can eliminate things, perhaps. And I confess, I don't know a specific SNP that's even sort of vetted as the leading candidate to look at, if there even is one, when it comes to anxiety, other than to say it's a known negative moderator of outcome, and it can be hard to treat if first-line treatments don't work. And when first-line treatments don't work, again, pharmacogenetics doesn't widen the pool of options. It narrows the pool by ruling out things that you'll say this is unlikely to work for. So that's another big unmet need.
Okay. And for pain, is pretty good pharmacogenetic data on pain. We don't have time to talk about it now, but I'll recommend the CPIC guidelines for the
Yes.
NSAIDs, the non-steroidal anti-inflammatories, and also the opioids. So you can find those guidelines on the CPIC website. And unfortunately, we are out of time. I'm sure we could talk all day. We still have some more questions, but thank you, Dr. Goldberg. I appreciate everything you've put together here for us. There will be a link to this. This has been recorded, so we will send out a link to this. And if you're comfortable, we'll send out the slides as well,
By all
Dr.
means.
Goldberg. Great. So thank you again. Appreciate your time. And thanks everyone for joining us today.
Thank you all.